Hello all, welcome to PhysioTV Classroom. The topic for today's classroom is going to be musculoskeletal assessment of the hip joint. This is going to be a quick assessment overview, you can say, or just an overview of the assessment altogether. So whenever we talk about the hip joint, it is going to be the largest and the most stable joint in the body. We know because it is one of the weight bearing joints, and it also connects from the lower extremity to the axial skeleton. So here it is connected to the axial skeleton with the help of the sacroiliac joint. Most of the time, if there is any injury to the hip or anywhere around the hip, the first one or the first movement that can actually tell that it is painful is going to be walking. Most of the time, even weight bearing on the hip joint, the quality of pain can tell you if there is any other structure involved or it is any pathology in the hip altogether. So here we understand that the forces that are coming on the hip are quite different with all the movements done by the hip joint. So in standing, in weight bearing, it is going to be approximately 0.3 times our body weight. When standing on one limb, considering it's going to be a unilateral stance, the weight bearing on the stance limb is going to be anywhere between 2.4 or 2.6 times the body weight. And again, walking on a stable or a level surface, it is dependent. Again depending on if the person is carrying any weights in his hand or is lifting anything, any object that has to be carried from one place to another. It can be anywhere between 1.3 to 5.8 times the body weight. Walking upstairs and running is going to create 3 times for the walking up the stairs, 3 times the body weight, and for running, it's going to be 4.5 times the body weight, or sometimes even more, depending on the surface and the speed of running as well. So coming to the brief patient history here, so even before we actually start examining the patient, we always start with their history. So here, of course, we always take the demographics to identify the patient, to identify their gender or their sex, or to understand their age. So here, why we need to know the age, there are many conditions which are quite specific to the age. So in infancy, it is going to be congenital dysplasia of hip, which is normally seen in girls. And there is leg calves Perthes disease, very commonly seen in 3 to 12-year-old boys. Then there is a possibility of osteoporosis, osteoporotic fracture, very commonly seen in the femoral neck, which is, again, the elderly women are more prone to it, or postmenopausal women are more prone to it. Then there is hip avascular necrosis, mostly common in males. It can be anywhere in the mid-30s to early 50s of age, 50 years of age. Then there is hip osteoarthritis, very commonly seen in females who have attained their menopause or are postmenopausal, and males who are mostly 50 years of age and above. Of course, if there is a possibility of pain, there are always different types of mechanism of injury which can be, or onset of pain, one of which can be a traumatic injury, traumatic cause, which can be a direct hit on the knee, which can be directly jarring the hip, which can be, again, there is a possibility of acetabular tear or even fractures with that. Then there is a fall directly actually landing on the lateral side of the hip, which is going to cause trochanteric bursitis. Again, if there is involvement of repetitive loading, which can cause a stress fracture of the femur, and sometimes it can be an insufficiency injury also. Most common one we normally come across for a hip condition is going to be the mechanical pain, wherever there is going to be twisting movements, which are quite painful. Sitting for long duration is going to be uncomfortable. Getting up from sitting can have a snapping kind of sound, or it can be catching. Ascending or descending stairs is going to be painful, and same goes with complete hip flexion and coming into complete hip extension. So that includes getting in and out of the automobile. It can be an auto rickshaw or even a car. And even putting on shoes, chappals, or socks can be painful. So again, this is quite an overview or maybe a summarized point that you can get of different types of pain and which can be the possible causes. So dull and deep aching pain can be arthritis, though hip osteoarthritis is considerably less common than we would talk about the knee osteoarthritis, but there is still a possibility of hip osteoarthritis, which can give you a dull or deep aching pain. Then there is Paget's disease. Then if there is a fracture, then the pain is going to be quite sharp and intense. Weight bearing may or may not be affected considering the type of fracture. Then there is a possibility of tingling or radiating symptoms coming from the lumbar spine, again, which can be indicative of radiculopathies, spinal stenosis, and might not be very common, but myalgia paresthetica is involvement of the lateral cutaneous nerve of thigh, which can be happening because of tight belt around the waist, or there is, if the person is very much used to wearing tight clothing around the hip joint, it can be leading to myalgia paresthetica. Again, when you talk about trochanteric bursitis, whenever the patient goes into a cross-legged sitting, the pain is going to be severe on the affected, especially the crossed leg. And whenever there is long duration of sitting and leading to posterior part of the hip pain, it can be indicative of ischiogluteal bursitis. Then pain after long duration of standing and walking, which has continuous axial loading, which is happening at the hip, can be indicative of hip arthrosis, sometimes even severe arthrosis, or even an occult fracture. Again, if there is an unremitting pain, or if the pain has been there for a very long time, it can be indicative of a neoplasia, or there is a possibility that the arthrosis is so severe that the pain does not come down no matter what. So again, once you see here, it is in the pictures here, this shows the, what do you say, a referred pain, if there is involvement of the hip intra-articular pain, it is going to be mostly in the groin, the anterior part of the hip. Then if there is buttock pain, it is normally associated with lumbar spine problems, again, depending if there is any nerve root being involved, or it can be indicative of a lateral tear. Then the adductor pain can be because of overactive adductors, also leading to or indicative of pelvic instability. There is also a possibility if the patient has been walking with a quite apprehension, making sure that there is no pain around, like there shouldn't be any pain around the knee if the knee is already affected. The patient tends to protect the hip, the knee, sorry, and they are going to strain a lot of their adductors. So there can be also one of the possibility of adductor pain. Next, coming to a sports hernia, it can be a dull aching pain around the groin, which can be, again, there might be a burning sensation, or there might be a radiation of the symptoms coming towards the lower abdominals or the perineum or even the scrotum. For the sports hernia as such, the symptoms can be acceleration, or even trying to kick is going to create severe symptoms there. Most commonly, there is also a possibility of a groin pull, especially in athletes or sprinters or even long jumpers. So when we talk about the lateral hip pain, again, when we are talking about the location of the pain around the hip, it is going to be quite indicative, especially for the lateral hip. It is indicative of trochanteric bursitis, or there's the possibility of tear of the gluteus medius. Again, common in older or elderly people. And most of the time, there is a possibility that the pain can be because of a nerve root involvement, most commonly the L4 nerve root, which can be because of a lumbar pain or a lumbar spondylosis. Though we might not necessarily come across so much of snapping hip syndrome, normally called as Coxa-Saltins, here what happens is whenever there is going to be a movement, the iliopsoas tendon is going to be grinded over the iliotibial tendon grinds over the greater trochanter. And whenever there is going to be a complete flexion and complete extension at the hip, there is going to be snapping, and it is going to cause a rubbing of the IT tendon or the iliotibial tendon over the greater trochanter. So again, considering the history, we are making sure that we know about what exactly is happening since the time of the onset of pain. So has the pain increased since then, or is it is so intense that the functions or the ADLs are getting limited? That can be one of our questions, which can be quite distinctive of the conditions that we know. And if any type of pain can be increasing because of activities like just resting or even walking and stair climbing also. If there are any movement abnormalities, especially during gait or even posture, which the patients feel there's a possibility that I'm not able to walk like earlier because I feel I have weak legs, or I cannot weight bear on only one leg because my muscles are weak and my pelvis tends to drop, can be one of the reasons or one of the important parts of the history itself. The Again, talking about what the patient would want to do, or what is his or her recreation or pastime, or what they do in their activities of daily living. If there is any repetitive positions, if there are any sustained positions, so if they have to be sitting in cross-leg position for maybe 1 hour, 1.5 hours, and immediately after getting up, it is causing a lot of pain, then we would want to know if there is any medical or surgical history pertaining to the hip joint here specifically. Also, if there has been any systemic illness, metabolic or inflammatory disorders. Also, when we talk about systemic illness, we would also want to ask if the type of medications they have been prescribed. So if there has been any history of steroid injections or steroid ingestions, also is very important to know about that history. Of course, any longer duration of steroid prescriptions can also be leading to the avascular necrosis. Also, there is a possibility of increased risk of osteoporosis as well. So coming to the gait assessment, when we talk about hip being involved, the weight bearing on the affected side is going to be lowered. The knee slightly bends to absorb the shock that is coming from the ground reaction force. Again, this is called as an arthrogenic gait, where there is going to be an imbalance of flexors and extensors as well. And again, if you see, there is going to be quite a deviation of symptoms or even gait here. Sorry. So there is going to be quite an out-toeing. You see, again, this is going to be happening to maintain or to protect the knee, the hip from the pain. Again, whenever there is going to be usage of cane, it is again, you can use it either on the the ipsilateral or the contralateral side of the pain. Here, ideally for the hip, it is advised to be on the contralateral side of the pain, wherein there is going to be a proper 3-point gait that is going to be maintained. And of course, it is going to be taught to the patient as well. So in the posture, the anterior view, the soft tissue and the bony contours are made a note of. If there is any visible swelling around the hip joint or even till the lower part of the lower extremity, that is till the feet, is also noted. You will be observing for the pelvic obliquity and also the limb position if they are going to be equal and symmetric. So there is a possibility of the feet being completely internally rotated or completely in external rotation. So that can also be a deviation from the normal posture. So here, when we talk about the posture, in the cases of if there is going to be an anterior hip dislocation, there is going to be flexion and external rotation with a little bit of abduction at the hip. That is going to be the resting position of the lower extremity. For the posterior hip dislocation, it's going to be a little bit of internal rotation, adduction, and maybe a little bit of flexion at the hip, which is going to be indicative of the posterior dislocation at the hip. If there is an intertrochanteric fracture, you see that the limb is going to be a slight bit of external rotation as well. At the lateral view for postural evaluation, the contour of the buttock is noted. Of course, you are going to check if there is going to be any hip flexion deformity or hip flexion abnormality as well. Posteriorly, we are checking if there is any deviation of the spine here. So the deviation from the normal spinal curvatures, if we are expecting or if we are observing any scoliosis here, if there is any difference in the bony contours and the soft tissue contour as well. So here for the weight bearing, to understand if there is equal weight bearing or not on both the sides of the hip, there are going to be two bathroom weight measurement scales, weighing scales to be used, wherein the client is going to stand on it and the weight on both the sides are going to be measured. Any deviation, at least 10% of deviation from the weight bearing is still accepted and considered normal as well. Now we'll move to the special test for the hip joint.
This is a measurement of or understanding where is the placement of the GT, or to understand if the hip is going into a coxa vara or valga. Here, an imaginary line is drawn from the ASIs, that is the anterior superior iliac spine, and it is dropped till the examining plinth. And another perpendicular line from the tip of the greater trochanter is drawn towards the imaginary line coming from the ASIs to the plinth. The last arm or angle of the triangle is supposed to be formed between these two lines. Now, with this you palpate if the GT, the greater trochanter, falls in the triangle or out of it. Whenever it is falling in the triangle, it is considered normal. Anywhere more than that is going to cause a pathology. So this is called the Nelliton's line, which is going to be a line drawn from the ASIs and it is going towards the ischiotuberosity. So this line is going to be indicative of measuring if there is any dislocation or if there is going to be any coxa vara or valga deformity again in the hip. So considering this line, if I start palpating the greater trochanter, if the greater trochanter does not fall below this line, it is going to be considered as a pathology or an anomaly. So if it is present anywhere here in the superior part, it can be considered as a dislocation of the hip as well. The next test is going to be Craig's test, which is normally done to understand if there is an increased anteversion at the hip or is it in the normal range. So in this position, for this test, the client is supposed to be in prone lying. Then you tell them to take the knee into flexion. So here you can measure one at a time. So this, what you would do is you palpate your hand and keep it at the GT. to make sure that the posterior part of the GT is parallel with the plinth. Here, when you make sure you do this movement and make sure you hold the GT in the parallel of the examining plinth. Here you identify the degree, making sure that the joint line of the knee is going to be parallel to the examining plinth. Here the expected deviation in the angle is supposed to be anywhere from 5 degrees to 8 degrees or 18 degrees for an adult. The maximum anteversion is going to be at the birth, which is going to be 30 degrees. Here I now let it loose, making sure that the posterior part of the greater trochanter is still parallel to the plinth. Here you can see as such there is no much deviation from the normal. Next, going towards the Ellis test, which is normally done to assess the tightness of rectus femoris. Here again the patient or the client is supposed to be in the prone position. Here I make sure I keep one of my arm on the lower back, making sure that there is no much deviation or flexion at the back. Now I try to flex the knee as much as possible, and as you can see there is going to be sudden hip flexion, and this is basically proving that the rectus femoris is still tight. This is basically to understand or this is a distinct feature which says that the rectus femoris is tight, hence to compensate with that the hip goes into flexion. Here to show you another view of the Ellis test. Here I go passively flex the knee, and as you can see the hip is by itself going into spontaneous flexion. The next test is called the hip scour test, which is to identify if there is going to be any hip pathology. Here the patient's limb is taken into complete flexion. With this it is also taken into complete adduction. With this there is going to be impinging of the acetabulum with the adductor muscles as well. With this, at some point you might feel a resistance. When you feel the resistance, you are continuing the flexion and taking it towards the abduction. The hip scour test can also be, or is normally also called as a quadrant test. This is to identify if there is any hip pathology because there is a lot of compression which is given with complete flexion, adduction and going towards the abduction. With this, whenever there is going to be a movement from complete flexion and adduction, which is supposed to be pointing out to the opposite shoulder, and you feel the resistance and are coming towards the abduction, make sure it is a smooth movement, or whenever this movement is done and you feel bumps during the movement, it is again indicative of a hip pathology. The next test is called the Faber test or the Patrick's Faber test. So the Faber actually says that it's flexion, abduction and external rotation which is done at the hip. In this, the therapist is going to passively keep the knee into flexion with an external rotation and flexion at the hip. With this, the therapist is going to give a slight push towards the plinth or over the knee of the flexed knee or the testing knee. If there are symptoms found on the anterior part of the hip here in this position, it indicates iliopsoas spasm. If the symptoms are present on the posterior aspect, that is mostly on the gluteal side or the posterior superior iliac spine or the sacroiliac joint, it indicates that there is a pathology in the sacroiliac joint. Most of the time, even with this position, the knee might not necessarily be in line of the extended knee here. This can also indicate that there is going to be a lot of muscle tightness here, or this itself says that the test is going to come out as a negative. The next test is called the flexion adduction internal rotation test. In this, the therapist passively takes the hip into flexion, into adduction, and then it is maintained in internal rotation. This is going to create a lot of stresses on the anterior part of the hip. If the symptoms are produced in this position, it can be indicative of labial tears, it can be indicative of iliopsoas tendinitis as well. Most of the time, it can also indicate, if the symptoms on the posterior aspect of the hip reduces, it can also indicate that there must be an involvement of the sacroiliac joint as well.
So this is the overview of hip assessment, musculoskeletal assessment. Hopefully this you like, and this will be helpful for you to understand how you would want to go about the assessment of a hip joint whenever you come across a patient. And make sure history is always important. Identifying or palpating the painful area and the bony and soft tissue contours, checking of bony and soft tissue contours is also important. And make sure the special tests you are going to use is quite relevant to the history given, and make sure you also have deduced the differential diagnosis as well. Thank you all. Thank you for being on Physio TV Classroom. Hope to see you all soon again. Bye.